not to use, no, they're not. In fact, we have it pretty well locked down where it can't be done.
Moving along, strategic plan.
Remember when we did the board survey, one of the things that we said we would do is quarterly as well, that we would bring the strategic plan. I want us to get to where we look to that strategic plan as our guiding work plan. And I think we've really got a good one because it touches almost all of the things that we're working toward. And I just want to kind of bring you up to date and fill you in quickly on some of the things that we have done to address. You also have a copy of your strategic plan there on pages 49 and 50 if you want to look back at that as we go along. The first section is the business literacy. Of course, mainly the focus on that is to have a bottom line. You know, we want to be efficient and have a positive bottom line. And as I said, revenue, and I got glasses so I can read all the way up there. Revenue cycle team is in place. It's headed by Connie Farrell. Of course, Chris is our facilitator. They'll meet regularly to discuss the revenue from admissions to collections. We've recently completed a 3-day on-site review of our charge master. The charge master is our outpatient coding and how we bill. We found a lot of things. Chris has got quite a few things from the charge master. But one example of something that we didn't even know that we've been missing all these years in our outpatient or in our surgical clinic, our auditor said that we had been missing, not our auditor, but the charge master person, whatever you call it, that we've been missing charges because we could have charged a facility charge on our Medicare patients, but we didn't know that. And so that's why it's important to have these individuals that's their business to come in and to know how the rules change. And this is just something that the Medicare pays. Now they may change that with all the new rules and all. About the time we get ready to bill for it, they'll change it. But we could have been doing that probably for the last 5 or 6 years. And so we've lost money on the table by not spending money to have a charge master review. So we now have that done. It's been brought up to date. We plan on having that done annually, and it will be less expensive if we have it done annually than waiting 6 years and then have it done. We have ongoing education of staff involved in coding changes. ICD 9 to ICD 10. This is just how we code, and it's going to change in October 12th. Is that right? So we have until October 12th, and that sounds a little way out there, but in our business, that's just right around the corner. You know, it really takes a lot of preparation to get everything in place for these changes. The new HIPAA 5010, this is also just some changes in billing practices, and it's mainly related to your electronic billing, like how we bill our insurance companies and all the people that we deal with. These are all changing, and we've got teams developed with that, and Chris is probably the facilitator of all those as well. We have a staff team headed by case management to continue education and review impact of the racks and the mix. We're monitoring the graft opportunities. I've currently, just this week, received information about the distance learning telemedicine grants that are opportunities that are available, and some state-funded grants for obesity prevention in children. So we want to take advantage of those if we can possibly, fit that into our plan of work, and increasing awareness of available services to aid in philanthropic opportunities by marketing. I think Karen's got a really good marketing plan. We're going up with another billboard out by Walmart to market our 2 surgeons and our community advisory board, and I'll mention a little bit more about that in a little bit. But those are some of the things that we've done for the business literacy. The second section is on service excellence. This is our patient, employee, and physician satisfaction. We want to continue to utilize LSUS for patient satisfaction for inpatient and home health. And we give in emergency department, we hand the patients a survey to complete. And we're not getting really good returns on that, so we want to try to focus on how to get better response of that. But and then we trend this. And this is another example of when I was putting this together, I hollered across the hall and told Karen to be sure to add on our next quality steering that this is an example of where you develop a team. We get the reports. You've seen in your packets the reports that we get from LSUS about the patient satisfaction. We all look at it and we say, well, we're up, we're down, and up in this, down at this. But that's kind of where we leave it. You know, we post them on the wall and we tell our staff, now we're low in this, we kind of need to do this. What we probably need to do is to develop a team so that we can actually have a plan. You know, what is it about, maybe if we're not giving a good service in a certain area, why is it? You know, let's drill down, see what the cause is, see what we need to do to fix it. So just saying, well, we'll do better next month is really not gonna get it. You know, we gotta do better than that. So, that will probably become a team in the future too. Okay. Clinical integration. This is where we develop collaborative efforts among healthcare providers. In everything that we read about healthcare reform, working closer with your physicians is going to be a key to it. Physician recruitment. We have added a number of physicians to the outpatient clinic. Did we put that list in here?
Yes.
Okay.
I think
You have a page that has our physicians that are currently in our outpatient lab or outpatient area now. We are very pleased to say that Dr. Hurley and Dr. Robinson from the Texarkana Cardiology Clinic have committed and set a date. They'll be starting on the 1st and 3rd Wednesdays afternoons of this month. And Dr. Stephen Greer and his associate, Dr. Jones, possibly may be coming, will be here on the 4th Thursday of the month, all day, from the Little Rock Cardiology Clinic. So we now have cardiology services for referral for our physicians here in town from El Dorado with Volker and Dodd, who have been coming. We have them to Texarkana and to Little Rock. So they've got good referral points. Of course, we've always had Dr. Gady and Dr. Wise, Dr. Smart, and we're thrilled to continue to have them with us. But we have also added Dr. Schonefeld, who is a nephrologist that comes one day a week, comes on the first Thursday. We are talking with Dr. Pippinger, and he may be credentialed here. I think he's going to be credentialed here tonight. Dr. Pippinger, he is a neurologist. He will be opening a clinic, and we're talking with Dr. Matthew Johnson, who is a dermatologist from Hot Springs. Had a clinic in Texarkana, but I think he's closing the clinic in Texarkana and wanting to come here. So we're really reaching out, trying to make sure that we get our physicians here in town the support that they need to be able to keep our patients here in town.
Margaret, let me ask you a question. These, Dr. Hurley, Dr. Robinson, for example, how do we make sure they're successful? Is it our responsibility as a hospital, or do we go out to the doctors out there and say, hey, docs, use these guys?
Well, of course, they've met with our medical staff. They each came and met with the medical staff, and I think, Dr. Franks, you may be able to, say something to that. I mean, we can't advertise for our outpatient physicians.
Okay.
I don't think there's anything we can do to make sure it's successful.
Yeah.
I really
It's-
don't.
They have to do it themselves?
Exactly.
I think if they give good service, they'll be successful.
Yes.
Okay.
But
So-
they have to let the
They don't
doctors
belong.
know.
We have no control of that.
Mm-mm.
But right now, we're gonna have 3 different cardiology groups.
Groups.
Yes, groups.
Groups.
Which each one of these groups have patients from this area now. Each
This is
one of them.
senior.
Mhm. So rather than them having to drive to Little Rock to see Dr. Greer, then they can do that here. And then we can also do some of the workup that they do here, some of the blood work and the echoes, cardiovascular, Holter monitors, that kind of thing.
Does Dr. Gady have anybody else that comes
No,
with
just
this
Dr.
group?
Gady.
Dr. Wise,
Just Dr. Wise.
Dr. Small.
Mhm.
And then tell us about Dr. Dodd.
Dr. Dodd has just recently started coming, he's from the medical center in South Arkansas as well. And, he's just recently opened a clinic and he's, seeing a few patients. He's actually using a surgery clinic in the mornings on the days when the doctor, and Dr. Hurley will be here in the afternoon. So. We'll see. Yes. Medical center in South Arkansas.
But he's a surgeon.
He's a cardiologist.
Dr. Dodd?
Mm-hmm.
Oh, I misunderstood.
And the surgery.
He's in the surgery.
Yeah,
I see
we're,
what
we're
you're
just
saying.
using that as a, because we're out of space. Okay, I met with a physician recruiter and we'll begin looking at the process of maybe recruiting a family practice physician that can take, you know, we never know what's out there, and what people are looking for, but we're gonna maybe start that process of looking for a family practice physician. Emergency staffing solution is completing, I was hoping I'd have it today, but I didn't get it, completing a feasibility study to employ a hospitalist Monday through Friday. We, of course, are covered on the weekends with Dr. Henderson, and we'd like to see if there is a feasibility, if there's a possibility, that could be, something that we could do here. Continue to keep up to date on the development of accountable care organizations and patient-centered medical homes. These are two new terms that you will be hearing many, many times. This is the new payment system. Accountable care organizations is where groups will be paid, for performance as opposed to being individuals being paid in fee-for-service. So this will be coming, it may be a couple of years before that's into the healthcare reform, but it's coming. And keep in touch with the hospital association releases and government releases on how healthcare reform will affect hospitals and physicians. Community value, with, of course, the focus is to promote the value of MRMC to the community. The Community Advisory Board, Karen and Julia Whitehead and Daryl Chatelaine headed that team up, and we are happy to say that Bruce Malik is our first facilitator. He agreed for a year, to serve for a year. They had 44 applications from the community, and they selected the first 15 members, and so we're hoping to use those individuals as extension of our marketing, so that we can find out what people need in the community, what they expect from us, and then we in turn can give them information to take back. We've conducted, of course, a community needs assessment that we reported in January, and we presented the 09-10 community benefit report to the city council. What we're planning on doing this coming year is to continue to keep records, but in addition to listing the services, we want to put a dollar figure to that, because when we have a health fair and we send about 10 of our staff out to staff a health fair for 4 hours, that costs us dollars. And so we need to put a dollar figure to that as well, so we're gonna try to do that. Campus employee strategy is strengthen our workplace. We want to encourage employees to find webinars that are free at low cost, and a number of employees can attend the training. And these are just a few of the things that we've done. Social networking has got to be, everybody's got Facebook, everybody's got iPads, phones. So we had a seminar, it was a webinar that talked about legal issues of having employees doing Facebook at work. You know, what are our legal issues as far as dealing with employees. So that was very, very good. we have one coming up dealing with difficult people, not that anyone has that. ICD-10 and HIPAA 5010, these are all some webinars that we've, done with that are no expense, that we can sit around this table in this room and a lot of people can see it, doesn't cost us anything. We conducted an employee satisfaction survey in October of 2010, and we plan on doing this annually and start working on some of the issues that our staff has. And the last one is the campus use plan, to efficiently and effectively use our resources. Our computerized physician order entry training is in the final phase of the electronic medical record to implement the necessary criteria to apply for reimbursement from the new Patient Protection and Affordable Care Act. I've been getting, just today, 21,000 hospitals and healthcare entities, some of them are physicians' clinics, have applied for the meaningful use, and this is the reimbursement that we will get when we get the, when we turn in our application. And they have paid out a little over $20 million today. So, is money out there, and if I told Chris I wanted us to get it there before they shut it down, because we plan on making our application in May. Right now, our physicians are in the process of doing computerized physician order entry, and that's the last phase of what we need to do before we can do that. So we're anxiously waiting that.
How much will we get?
Well, there was a hospital that was about an 84-bed hospital that got $400,000. Now, I don't know how they base that. I mean, if we could get, I'd be happy with 100,000 or whatever. You know, we don't know until we get it. But we should meet that, like I said, in May. The physicians in town and out of town. This is the great part. And Dee Rogers kind of hit on this just a few minutes ago when she was talking about how it has changed how we do business. ChartLink is something that's part of our electronic medical records that would allow the physician to pull up their patient's records, to review x-rays, to look at different aspects of their patient care in their offices. We have Dr. Pulley is set up in Hot Springs. We have Dr. Harden in El Dorado, who is looking at those. That is the reason that our echoes went up, is because we have Dr. Harden looking at those, and we don't have to wait on someone to find the time to do that. One that was not good on there that I forgot about was our cabin clinic that's in Louisville, and they were the reason that we were able to actually apply for the USDA distance telemedicine grant, is because they put us in the rural area. Even though we may think we're rural, the USDA says we're not rural, we're mid-rural, and so we have to work with someone who is rural. And so the cabin clinic, Dr. Arrington is hooked up to us, and of course the radiology consultants in Texarkana. And we also, so the world of technology is, it is here. It's here to stay, and it's going to grow. In fact, UAMS will be here this Friday to discuss implementation of the Arkansas Save Stroke Telemedicine Program. Well, they'll actually have equipment that we don't have to pay anything for. They will put it in our emergency room, and we will have access 24/7 to a neurologist, either in Little Rock or Fort Smith, so that our ER physicians and staff physicians will be able to consult with them. So this is just the first step, and I think what we're going to see is a growing trend in telemedicine. So that's kind of some of the things where we are on our strategic plan. Does anybody have any questions?
Why is Nighthawk not up there?
Not up.
Right now, it's called Nighthawk.
Yes, we do. They are in, through Texarkana. So, no, I don't know, they may be off, really, I don't know where they are. lunchtime. They're not supposed to be walking around with a cell phone, so that if they're doing whatever their job is, whether it's patient care or, you know, cleaning rooms or serving food, you know, you don't stop what you're doing and talk on the cell phone. You know, you turn it off, you put it in the locker, keep it to where, you know, you can use it during your break time at lunch.
So does that mean that, on a hospital computer, they're not supposed to use Facebook?
No, they are not to use, no, they're not. In fact, we have it pretty well locked down where it can't be done.
I think that was an excellent presentation. Anything else from the administration? Chris, anything else from your end?
One quick thing I wanted to point out, tomorrow is the start of our new retirement plan, kicks off. It has been a long 2 weeks, trying to get all this input, but I'm gonna compile some numbers, kind of see what type of, rate we had of people joining it, but it was a lot of people joined this, especially a lot of our younger folks, and a lot of times say they can't afford to do it. They are jumping in and, gonna start working on building themselves in retirement, so we'll, hopefully by the next board meeting, we'll